which is this: complete dentistry and full mouth rehabs, or whatever you want to call them, only happen when the patient says yes.
Yes, absolutely.
And, we as dentists are dreadful communicators. And we say things like, oh, Mrs. Jones, you need 17 crowns, and you need to have equal intensity contacts and posterior exclusion and this and this and this. So when would you like to get started? And we wonder why they don't do it. Digital is a fantastic communication tool.
Hello, Protrusive. I'm Jaz Gulati, and this is episode 57 of the Protrusive Dental Podcast. Thanks so much for joining me. In this episode, we will talk about digital occlusion, and not the nitty-gritty, overcomplicated kind of stuff when it comes to occlusion, the really important stuff, like, for example, how to use digital photos and digital scanning to make sure that you do not get cants in a patient's smile, how to predictably raise the occlusal vertical dimension using digital techniques to make sure that when it comes time to fitting the provisionals or fitting the definitives in the patient's mouth, then everything will be much more likely to work and need less adjustments, because really that's what occlusion is about, doing less adjustments and more predictability. Okay, so I'm not sorry that this is such a long episode, right? This is a mammoth episode. I really appreciate that. So you might have to do it like in 2 commutes or 3 commutes, or that's a lot of onions you have to chop to listen to this episode, but there is a reason for this, right? The flow was just too good. Like originally I was gonna do this as a 2-part episode, but I just loved Ian's storytelling. So for those of you who know Ian Buckle, he was an educator for the Dawson Academy in the UK, which I don't believe exists anymore, but I did all the modules of Dawson with Ian, and you know what? I hung on to his every single word. He's such a great educator, great storyteller. I learned so much about occlusion from him, but also about communication. But my friend, I appreciate that this long episode is not for everyone. So if you are really hungry for that special knowledge, that hot tip for digital occlusion, and when Ian gives it away, then I would probably start listening from the 52 minute mark onwards if you really, really want to, but you will miss out on a lot. So for most of us who are happy to listen to the journey and listen to his stories before we get to the sort of the sexier part, which is the actual how to make digital occlusion work for us, man, you are in for a treat in this episode. In the beginning, let me just put this into context for you without actually ruining the story. The story is that imagine you or your partner is pregnant, and the doctor tells you that the baby will have lots of conditions, disabilities potentially, and one of those disabilities or complications is that your baby's teeth, the baby that will be coming to this world, your baby's teeth will be malformed. Maybe they will not have any teeth, right? So when Ian found out that this was going to be happening with his daughter to be, he was heartbroken, right? So what do you do as a dentist, right? If you're told this, what's the one thing you could do? Well, the one thing you could do is at least you can fix the teeth. And so that took Ian on this journey of learning and upskilling and making connections so that when the time comes, he can help his daughter and he will have a team around him to be able to help his daughter, which I just think is so noble, right? So that's his story, and listen to that and how that inspired him. But we also talk a lot about career decisions. Should you specialize? Should you do a master's? Or what are the complications in going in a private route and just upskilling with courses? So we talk about these themes. So there's loads of communication gems in there, which you would expect for an episode with Ian Buckle. Now, just before we join the episode, I want to share the Protrusive Dental Pearl for this episode. So many episodes ago, I gave you a pearl which I think is now false, right? So I changed my mind. And another pearl I gave you in the episodes was that there's something very unattractive about someone who can't change their mind. So I think it's a beautiful thing that we can change our minds. And so the pearl I want to adjust is the one where I told you that how you do anything is how you do everything. So how you do anything and how you is how you do everything. So there is some beauty in that, and I think there's a lot we can learn from that. But let me tell you why I've changed my mind, right? The time right now is 5:50 a.m. I woke up at 4:15 a.m. UK time. I did my beard, which is a thing. When you got a beard like this, you have to tame it. And I had coffee, had breakfast, and now it's 5:50 and I'm recording this. And I'm telling you this not to gain your sympathy or your bravado or anything like that. It's because last night I was supposed to do some recording. So it's supposed to be an evening session. My producer was supposed to have it by now so he could start working on it, but I didn't do it because my son was just in such a great, so my son is 18 months, his name's Ashan, he's 18 months, and wow, he's developing this unique personality, he's got so much energy, he's just bouncing off the walls, and last night he was a comedian, he was being a comedian, he was just doing all these shenanigans, and I was just loving every moment of it. So I just decided that, you know what, I will not be doing my recording, I will be spending more time with my son, and I don't regret it at all, I love it, and so, because this podcast needs to come out there, and I value you, and I value listenership, and I value the podcast. I love podcasting; it's so much fun, right? So I am up early to do it, and I've got good energy about me, as you can see. Hopefully, I'm not sounding like lack of energy or anything like that. So the lesson to be learned here is, what do you value? Because whatever you value, that should govern what you do care about and what you should give everything for. For example, on the Protrusive Dental Community Facebook group, Sheetal Kabanda. Sheetal, buddy, what you posted was, you said, is there a way to get Alexa to play the Protrusive Dental podcast? And I sort of made a video saying, look, Google can do it, Siri can do it, I'm sure Alexa can do it, right? So find out if Alexa can do it. If not, I'll make it happen. And then when I post that video, I realized, oh my gosh, my desktop background is so messy, right? So who else has a really messy desktop background, right? So I've got a very messy desktop background. And then Dami Bakare, old friend from dental school, he commented saying, wow, that is one messy background. You're such a busy guy. And I was like, oh gosh, he's right. It's such a messy desktop background. And I thought, why is that? I'm pretty organized in my dentistry and stuff. And so why is it that my desktop background is so messy? Well, I thought about it and I thought, you know what? I don't value the desktop background. And I think sometimes we have to limit all the things we value. You have to write them down. And that's what you will apply. How you do anything is how you do everything, right? Because it's impossible to do everything at the highest level. So last night I valued my son, and I value my son, so I spent more time with him. I'm valuing you, and I'm here right now recording in the morning. I don't value the aesthetics of a clean desktop background, and also I don't have normal person OCD. Obviously, as a dentist, I have OCD when I'm doing teeth, but normal person OCD I don't have, so I can live with a messy background. I know some of you probably can't. So it's all about what I'm trying to babble here is that find out what is it that you value, make time for it. You'll always make time for the things that you value, and things that you don't value will get squeezed and crushed and moved to the side. And that's totally cool. Don't be too harsh on yourself if that's the case. Accept that that's the beauty of it, that you can value some things and really give it your all, and everything else that you don't value doesn't deserve the best of you. So I hope you enjoy that, Pearl, and let's join Ian Buckle with the story of digital occlusion.
Still, it was very basic. It was pretty basic dentistry in those days. And then, I sort of moved on. You get a little bit more interested in dentistry. And probably the first thing that we were able to get better at, if you like, was endodontics when rotary instruments came out. And despite what many people might think about me, maybe you as well, Jazz, is that I'm quite a shy person. And I remember going to this section. Well, I had to see, I was brought up in the generation with my grandmother saying children should be seen and not heard. So I knew my place. So I went to this Section 63 meeting, and I was, I thought it was very interesting that I could get good at this, and I wanted to provide good care for the patients, and also have an interest for myself. There's a selfish part in there as well. And so I stayed behind, waited till the end, and I said to the guy who happened to be the dean as well, I'd really like to get involved. What is it I need to do? And it's just like, well, it's a 3-year course, full time. If you don't like it, you tough luck. And it was extremely disappointing, because I had a young family at the time, a mortgage like everyone else, all those things, and it really just seemed like a massive obstacle, and I didn't know how to get past that. I always like to mention my friend Mike Horrocks at this stage, because Mike was around. He was a year or two older than me, but he went and got on with it and did it. And what he's done with his endo stuff, I think, is fabulous. And the way he's encouraged practitioners to say, look, let me show you how to do a better endo, and then it gets people interested. When you get someone interested, then they start really getting into all the other stuff and the research and And there's different ways of doing it rather than that traditional 3 years, sit, study some stuff, and then come out and think you know everything. I think there's a great way of learning. I think a lot of us in dentistry are very practically based. So we like to do something, and then when we've done it, then we like to find out how did that come together? How did it work? So that was my first sort of thing, And then
I just wanted to stop you there and say that what you said there was very relevant to some of the themes that we've had with the guests on the podcast before, whereby we've talked about the specialist route and actually doing the MCLIN Den in pros or endo or whatever, and then there's the sort of the other route, which is the one I'm pursuing. I'm doing external based courses. I know my limitations. I'm using mentors as much as I can. And there's a whole beauty of that side as well, which I think sometimes when you're a new grad, you're all starry-eyed and you sort of map out your career path. Okay, I'm going to do dental foundation, then a core training in hospital, then I'm going to apply for my MCLIN Dent, and then I'll be a specialist. And a lot of people, about 50%, I think, seem to be geared towards that. And then the real world hits you, mortgages come, the time thing comes, children come, and then you sort of think, actually, there's this whole other route that it's very fruitful.
Yeah, no, for sure. I mean, you've got to be respectful of anyone who puts time into anything, but I think both have value. I obviously have experience more of one than the other. But dentistry at the end of the day is a hands-on sport. It's a practical thing. And learning while you're doing the job, I've always seen dentistry as an apprenticeship more than anything else. I think I'm still an apprentice, so we should all be apprentices. But so I think there's value in those. But I think because everyone does it doesn't mean it's the right thing for you. I think there are some great opportunities in postgraduate education that aren't along that MCLIN Dent. And, I think be careful what I say, but I think there's a lot of things out there which is about getting a piece of paper rather than actually what you need to know to be a really good practitioner. I think there's advantages in having the piece of paper. It's too late in the day for me, but I think there's advantages to that. And I can imagine how that sits in the modern world. But certainly I think the absolute key is what you just referred to, which is whichever it is, get yourself a mentor, get yourself someone who you can resonate with, get someone who has, your best interests at heart, not theirs. I think we talked for years about having a teacher's heart, and really what that is the whole idea is the purpose of teaching is to get your students to be better than you are. I mean, I was sort of quite late to the game in many ways, and I don't regret it because I was busy doing very interesting things. But again, it's that old expression, when the student is ready, the teacher appears. But to have someone, find someone that you like what they do, that you think has a good ethos and is ethical, etc., and then ask them if they'll help you. I mean, there's a lot of we're so fortunate in dentistry that there's a lot of great people out there who will help you and guide you towards the things that will help you in your career path. I think one of the things that we talk a lot about in dentistry, but I think it's just as important, if not more important, in life and in your career, is to have very clear goals for what it is you'd like to achieve. I know, I mean, it's a little bit strange for me now because, I talk about these things, and like my son's going to be 30 in a couple of weeks' time. So, he sort of lived that whole thing with, but what are your goals? Where are you going to end up? And, I can remember him saying to me, but I don't know where that's going to be. None of us do. But the thing is, if you don't have a clear goal, don't be surprised if you end up somewhere you didn't expect. Very often, it's our best guess right now. That's what we're aiming for. So if you're not absolutely certain, don't be afraid of that. Don't be shy of it. It's your best guess right now. Go for it, and you'll be things. Fate will take its hand. You'll see other things along the way. Maybe you'll refocus your goals. But planning is really important. I really like being a general practitioner. That's what I want. That's what I want to do. The dentistry is about people. It's about the whole functional system. It's not just about teeth. It's not about perio. It's not about ortho. And certainly when I was taught dentistry, it was very departmentalized and almost everything was competing against each other. Well, my patients just want me to look after them and look after them appropriately, and to have the knowledge and advise them. So it doesn't mean to say that you're the expert at everything. There's a lot to be said for being a great generalist who can do a lot of great things, can serve our patients tremendously well, but also just know stuff so that if the situation needs it, then we can refer or get involved with other people that help us. I mean, I am incredibly fortunate now. I have a tremendous periodontist and orthodontist and all sorts of other people that help me out when it gets beyond my range, but we all have the same goals. We're all looking to achieve the same things. And so,
but Ian, one interesting thing you mentioned about your orthodontist and the great team, but people need to know that you're very unique in that when the right case comes along and the best person for the job is your friend in San Sebastian, Alberto.
Yeah,
so a lot of the patients will come to you in the Wirral, and as part of your comprehensive diagnosis, some of them will end up having orthodontics. Am I right? And they will have a little jolly in San Sebastian and see Alberto. Is that right?
Well, yeah, you've got the theme correct. I mean, we again. I came across Alberto. Alberto's actually in Barcelona. Domingo is in San Sebastian. Both are great cities to visit as well. So if you ever get the chance, it's great. I came across both of those guys as part of my journey, and it was going back to what I was saying before. We talked about endo a little bit. I always wanted to. The thing I liked was to try and make teeth look like teeth. It was just a bit of a fascination for me. And we came across, I won't go down that line at the moment, but came across many dead ends as far as that was concerned. And, the cosmetic stuff helped me a lot with that. But almost 25 years ago, our middle child was born, and she was born with a genetic disorder called incontinentia pigmenti. And part of that, when she was 6 weeks old, we were told she might be blind, deaf, mentally retarded, a skull might not grow, all these different things. But as part of that, she might have missing and misshapen teeth. And I think many of us as dentists, we just love to fix things, and obviously when you're told things like that, you sort of takes a little bit of getting used to, but out of it, it's go, okay, so what can I do? And the only thing that I could do, because most of it was just about waiting, but the only thing that I could do was to try and get to know the people that could help her if she needed it when she was older. And I knew she might need ortho, I knew she might need implants. So I personally, I was much more interested in aesthetics, cosmetics, whatever you want to call it, and trying to make things look nice and make them work well, because, our American friends are very cosmetically based, but, with us being Europeans and British, we know that it needs to work properly as well. So I was fascinated about how to bring those things together, and that sort of led me towards Dawson and all those other stuff. But with this, it really brought me on that journey to try and find particularly orthodontists that would put the teeth where I needed them to go. And as I was, that whole Dawson thing, as I said, it was more about being a designer. Where do the teeth need to go in the patient's face to make them look great and work well and be biologically healthy? And that's what that's about. It's about design. And then how you get them there is really between you and the patient, which is about an appropriateness and what's best for them. I mean, some of that cosmetic stuff got a little bit out of hand, and, it was diamond-driven orthodontics, but I mean, that's just misuse as often we do. But the interesting thing is, is that if you look at Pete's book from 50 years ago, it talks about treatment options. He talks about reshape, reposition, restore, and then surgical stuff. And when I first saw that list, I thought, well, that's great because I like restoring teeth. I'll choose that one. But actually what he was talking about was, this is the most minimal way to do stuff. Maybe we could just alter things a little bit. Maybe we need to move the teeth first. And again, if you look in Pete's book, he was using rubber bands and paper clips and all sorts of things to try and move teeth, just to get them in the right place to minimize preparation. And the restoration was just a bit on the top. And certainly if it's going to be my daughter, what would I want for her? Well, we need to put the teeth in the right place. So what I have to do is minimal to nothing. And through that, so through all this, I came across a group called the FACE Group, was known in the States perhaps more as the Roth-Williams Group. But they actually practiced orthodontics with the same goals that I had in my prosthodontics. So they like the stable condyle position. We like the teeth to come together at the same time. We like a nice envelope of function and guidance, etc. So we had some people that were looking at the same thing. They weren't just straightening teeth, So I came across those guys. I actually came across a guy called Carl Roy over in the States, who's phenomenal and such a nice man and helped us tremendously. But he said, Ian, you should go meet Domingo in San Sebastian. He's much closer to you. And I'll be honest with you, at that stage, I'd had a lot to do with the States. And I thought, well, I'll go and meet him, but we'll see. I think we'll be coming over here. And Domingo is just the most charismatic person, the tremendous guy, orthodontist, the most motivational person you could ever meet. And his right-hand man was Alberto, who I've just had tremendous pleasure working with. And so we actually, with no disrespect to any of my countrymen or wherever, my decision was that if I wanted to get these teeth exactly where they needed to go, then I was prepared to take it to San Sebastian every 6 weeks to have a treatment done, which is what we did for almost 3 years,
But it blew my mind when you told me that. But it blew my mind even further that you've continued that relationship now, and you send your patients the right patient who has everything aligned and it works out to get continual treatment in this modality of referring. Getting a flight going to a very nice part of the world to get some orthodontics on a regular basis. It blew my mind, but it showed me so much about how much you care about the vision, the end result, and you found someone who, a team that is so in tune with your philosophy.
Oh, Jess, we talk about this, and we talk about what do they call it? But they call it the daughter test. So what would you do for your daughter? Well, nothing could be further, be closer to the truth, I should say. For me, you do anything. So it was really just a case of if I believe it's the right thing to do, misguided as I may be, then that's what's going to happen. So, but through that, I've had some of my orthodontic friends take the face training courses. So, we've had, I was very fortunate we had Alberto working here for a while. And then, we have also worked with other face trained orthodontists here. But we do get, Alberto for me and Domingo are sort of top of the tree with ortho, TMD, surgical things. And so, I mean, for better or worse in my practice, I see some very challenging cases now. And, my goal and my duty more than anything else that I do is to make sure that patient is taken care of as well as I can. And, I think, I say I don't wish to be to comment. I'm sure other people have better situations than I do. But sometimes I'd send patients to the orthodontist, and the teeth would come back where the orthodontist wanted them, not where I wanted them. You send them to the implantologist, and the implant is where he found the bone, not where you wanted the tooth. So for me, everything was about the design, the final design, and then we got everything into place to do that. And so I needed guys that were respectful of it. And that's where my team was. And when it came, particularly when it comes to, I don't think anything could be more challenging than orthodontic stuff. And so you need a great team of people who I know is going to take care of someone. And Alberto has a phenomenal team in Barcelona. So, until, I'm hoping to find someone in Thornton Huff just up the road, but that hasn't happened yet. So
Well, let me tell you what I'm doing now to hopefully have someone. So you inspired me massively with that when I learned about that. Then you actually introduced me to the face group, and I was actually at the time I was doing my diploma in orthodontics. And now a good friend of mine who's now a specialist orthodontist, I won't embarrass him, won't name him. He messaged me the other day saying, "Jazz, I know you're into occlusion, you like that kind of thing. I'm considering to go to Seattle to do the course. He's an orthodontist and he wants to do the course." And I said, "Hang on a minute, hold your horses. Have you heard of the face group?" So I joined the Facebook group for face, and I invited him, and I'm getting his exposure in a little bit of selfish way that hopefully one day I'll have an orthodontist nearby who will have this sort of same philosophy. So thank you, Ian, for introducing me to so much and something that's so broad. And it was a great thing to be able to give him sort of a pathway as well.
Well, the fantastic thing, Jez, is we talk about this, and then as I say, I'm glad we sort of haven't got down those sort of like occlusion war type things, which is all the little details that people debate about. The best thing you can do is get with colleagues and talk. Again, a lot of the reason why things don't work out with orthodontists is you send a letter with no detail on. They do whatever they feel like, and then we wonder why we didn't get the result that we wanted. Why is that? Because there's no clear goals. So, the thing is to find an orthodontist, to find people who have the same goals as you, who want to listen, who want to work as part of the team, who have the ultimate goal to take care of the patient. And if we can do that, then we can hopefully point them in the right direction to get the training that they need to be able to do it. So I commend you for that. Nothing would give me greater pleasure than for all of us to have an orthodontist, etc., close by that could do these things. But until then, I'm still going to advise people this is what I think is best, and then it's up to them whether they do it or not. We all make our decisions. So. But that was a big commitment for us. She got tremendous treatment. She unfortunately had me to finish it off. So she's now 20. She'll be 25 in a couple of weeks' time.
I've seen her smile. She's come to one of the dinners. So it's amazing. So you've done great work and as a team. So
well, thanks, sis. But and she's the most important thing is she's very happy, and it's given her a huge amount of confidence. I see through that I came across a lot of youngsters who had similar problems, and there's just I've got one. I'm sure there's lots that are very successful, but I just one that springs to mind. This lady, she'd been having orthodontics for 14 years, and she actually had the same problems as Dulcie. But the reason why she'd been having ortho for all those times is because there was no real plan, and there was no real design, and it actually came back to I was sent as a dental problem. Because when you don't have teeth, you have small jaws and X and Y and Z and all these other things follow. And we look at teeth and we look at jaws and we think about how we do that. And the first question I asked Amy is, what's your problems, Amy? What can I do to help you? And she said, I really don't like the way I look. And I said, is that your smile? Or she said, no, my face. I really don't like my face. And because she's got small jaws, she's got the nose and the chin coming in. She got very small mouth, and she was 22 years old, and she's saying to me, "You know what, Ian, this isn't getting better, is it?" And but that is it's an aesthetic thing. I think it's a really important thing. But here's another thing. So then when you do your complete examination, which is of course my hobby horse, it's like, well, you notice the dark rings under her eyes. Did you sleep okay? Well, not very well. And to cut a long story short, she had severe sleep apnea.
Mm-hmm.
So she actually had surgery and ortho and implants and whatever else. But she now breathes properly. She's healthy. She's well. She's got a beautiful smile. She's loving life. So, but it comes down to that. Forget that you're a dentist. Forget that you're an orthodontist. Forget what is it that the patient's looking for. they didn't come in because we've just bought a scanner. They didn't come in just because we've bought Invisalign or whatever it might be. They came in for your valued opinion. Now we all go on the internet these days and we come up with these crazy things like, all my teeth are falling out. Do you do pinhole gum surgery? So, yeah, but how are they related? That actually was a patient this week. So, and we choose what we think is appropriate. Our job, or my job, is if my pal walked in the door, which he did yesterday, and said, "Hey, Ian, what can you do to help me?" That's what I'm there for. I just got to use my knowledge to help them as appropriately as possible. So it's not just about teeth and ortho. It's about the patient and what's appropriate for them, and actually trying to help them be healthy for a lifetime. That would be the best. The secret of a good job is that no one ever really appreciates it. So I'm hoping that in 30, 40 years, when Amy's there, she's not even thinking about what's gone on because it just worked well for her and she was being healthy and well, and she doesn't realize what the other path might have looked like, So So that's my.
That's philosophy. This is your origin story. This is your philosophy.
Yeah, and it's just about taking care of people and trying to do the right thing. And we also get plenty of people. We talk about those things, but maybe it's not appropriate for them, or for whatever reason. And sometimes there's other things that we can do for them, which maybe isn't as optimal. And compromises can be okay, provided that we don't harm people. And that everyone understands the compromise. We always plan for the optimal, but there's compromises. Life is full of compromises. It's absolutely fine, But we just got to understand there should also be a line at which we go, that's I'm not doing that. I wouldn't do that to my pal. I'm not doing it,
I'm getting flashbacks from being on the courses with you in the Wirral. And one of the most biggest takeaways I had was just the way that you communicate with patients and how you pass that on to us. And these little lessons that, you've burnt your fingers. You're not afraid to share the times that you've burnt your fingers, ask me how I know kind of thing. And you pass that on to us. And the quotes and the sayings that you had. One of my favorites being, when all is said and done, more is said than done. And, all the various things that, I sort of memorized what you say. And one of the episodes I sort of talked about the thing, one of the pearls from the episode I gave was how I now start most of my new patient consultations saying that the secret of success is to be thorough in what you do. And that is then my cue to do everything exactly A to Z comprehensively on every patient every time, so they get the best of me. And that's that starts it off. So there's so many communication gems I got in there. So now we know your origin story and your philosophy. And now I'd like to go deeper into the part 2, into digital occlusion.
I just want you to know, those little sayings that I have, they didn't happen overnight. I often think a lot of what we do is like comedy. It's like you tell a joke, it goes okay, but if you tell a joke and it works well, you make sure that stays in for the next one. Mm-hmm. And it must have taken me 5-10 years to come up with that little saying that I've given you in 5 seconds. So I'm glad you're using it, and it just gets you started. And and this is the thing about mentors and things like that, is like my whole, it wasn't always an easy 5, 10, 20 years. So one of the things that eases the pain for most of us who cared about those things is if I can get other people and share that with them, it makes it worthwhile, So and then eventually you maybe find your own little phrase, which is better still. But it's a good start. So thanks for following.
No,
so
you're
now we're going to talk about digital. There's another word for that, but I can't use it on a polite podcast like this. But storytelling is interesting as well. I think I've always enjoyed stories. I've always enjoyed comedy. I've always enjoyed communication. See a lot more about storytelling now as a way of communication. And much as I really like to learn about stuff, it's sort of almost like I don't want to know, because I was just doing it because it was me. And now I'm learning out why I do it. If any of you like TED Talks and things, if you go on some of the TED Talks about storytelling, there's some there's an amazing guy on there, and he talks about how, as you tell the story, the different chemicals that it releases, and how you can sort of basically manipulate people, which is not my intention at all, but but it's a very interesting thing. But I think for not just centuries but millennia, we've all been communicating through stories, and I think it's a great way of getting this. So anyway, let's move on to digital, because that's a fun thing and will make me feel a little more.
That's a bit I've been getting all these questions sent in about, and that's the direction we're going to take this, the part 2 of this podcast now. So digital occlusion is essentially, the foundations of occlusion. And what I've done with you, with Dawson, and we'll come on to the end about, the future and stuff, but it's a lot of the analog teaching. And you gave you a few snippets of the digital stuff. But now that I've been using the Trio scanner for about 3-4 years and the iTero, I'm loving the digital workflow. And I just want to learn from you and share with the listeners a few tips and pearls and some background information about how you merge building great, long-lasting occlusions and beautiful smiles, which go hand in hand, into the digital workflow. So you've been doing digital for a long time. Just tell us a little bit about how you got started in digital and what percentage, is that fair to say, what percentage of your work you do is pretty much digitally oriented? I mean, I know when I was there in the Wirral, you're scanning and you're printing your own B-splints in the practice. So you're very far ahead, from compared to me anyway. Tell us about your sort of digital experience.
When I was at Liverpool University, I say 35 years ago, I qualified. So a few years before that, we actually had the CEREC machine. And there was a guy there, Nick Jednikavich, and he was he was a dental geek, and so we loved all that stuff, and we were very dissimilar in lots of ways. But I had an interest in dentistry, and I really had an interest in computers, and I was fascinated by things like that. So it seemed like a good idea. My brother-in-law at the time was a designer, and he was really getting into computer-aided design. And so I used to spend a bit of time up with him as actors, seeing what they were doing. And I was thinking, this is phenomenal what we could do. But in those days with the CEREC machine, you'd take a block and you put it in the machine. It would be in there for about 4 hours, and then you'd take it out and carve it to fit the cavity and pretend you'd done something that was worthwhile. But it did seem like a good idea. And then over those years, we had the red cam and the blue cam and all those things. And, CEREC, and Sirona, God love them, were sort of market leaders in those fields. And a lot of it was based around single tooth dentistry, so it was really more about in-house milling than anything else. And so over time, and as I got my own practices, then I came to a point where, we were able to, again, standard was important to me. So it was important that we could make good restorations. But I was doing a lot of inlays, onlays, and posterior crowns, which I thought I could do very nicely with digital. So we became very, very efficient just with in-house milling of single posterior restorations. And occasionally we'd fool around with anterior stuff, and it was a lot more challenging. And there was people out there showing great things, but I didn't ever really want to be a technician. I didn't really, I don't know that I've got that skill set. But I try my best, and in the right cases, I'd have a little go. But that's really where we used it, and it was a very useful tool. But then there's really been a massive leap forward. And I think, history is important, and I've been using it for a long time. But as you say, that was more about in-house milling, single restorations, mainly posterior. That was one side of what I did, which would fit into a bigger treatment plan if that's what I was doing. And that was for me to decide. But then as I really started to, I think, understand the analog system of complete dentistry and examination and records, and then how to treatment plan, etc. It sort of gets you wondering about, how could you do this in the digital world? And because some of the stuff that we're doing is a pain in the neck. It's and so one of the cool things is that I'm very fortunate as part of my teaching that has taken me to Scandinavia, and through that I came across 3Shape, which is a Danish company, and they actually, whereas Sirona and Serec more came at it from the clinician's perspective with in-house milling, they were more a laboratory-based program, and say they were coming at it more from lab design, and then sort of the scanner and thing was tacked on to the end of that. But because of that, they had certainly at the time, a much more powerful system. They had an orthodontic program, they had a restorative program, they had all these different things, and so then I became fascinated about how we could make all these things talk to each other. The problem, as I found out, was that they were very departmentalized as well at the time, and some of the programs were written in different languages, so they didn't talk to each other. I was like, oh no. Mm-hmm. So the main thing that I have going for me is that I persevere. I crack on. And so whereas a lot of the time people get put off, I'll usually have a little bit of I usually say a few bad words, and then I go, right, well, what are we going to do to make this work or better? And at the time, of course, everything gathers pace, and it gathers pace because, that people can spot a market, because that helps a great deal. But then, the scanners were getting better, the accuracy is improving tremendously, and we're thinking, well, how can we use this to look at some of these bigger cases? So, very simple thing, taking impressions. Well, taking impressions is you got to get a good impression. If you go to a lab and you see most of the impressions that are there, you'll see that at least the second molars are missing, or distorted in some way. Taking a good impression is a difficult thing, but with a scanner, you get to see your impression straight away. There's no escape. So you get to be honest with yourself about what's there. So we could certainly make sure we got some great impressions with digital. And I didn't have, instead of having to duplicate models all the time, I could press copy. I like things like
so
that.
much better. I love that.
Yeah. So there was so many things that even simple things like that, sometimes you forget now. They made it so much better. But as you say, a lot of the time I was printing models and then put them onto an articulator, and so it went on. Digital orthodontics was coming on, so we could actually start to move teeth and see how these would look, which was again a deal better than sawing teeth out and doing sort of Kessling setups the way we used to. In-house restorations was going real well. Also, the fact that I could work with a lab was great, because I could scan a patient and they had the information in seconds rather than 3 days. Nothing was worse than an impression going to a lab only to get a phone call to say, that impression you took in is not the best. Whereas now, if we wanted to, if we weren't sort about it, the technician could look at it straight away and go, yeah, that looks great, let's carry on. So it was a great communication tool. So there was so many bits and pieces that were coming together. Implants, if you look at implants, look at digital. A lot of people associate digital with implants. Oh, because we've got, everything is driven from CBCT, and we're going to make this guide, we're going to do this. And it sort of lends itself to that. That's just one part of it, So how do you make this big picture fit together? So, we come back to, this sort of, whether it's Dawson, whether it's Spear, whether it's Coist, it's about this sort of complete care and looking at the big picture, and how, if you come right back to it, don't forget the complete examination. Digital will not save you from being a good dentist. You got to know how to examine patients, got to know how to communicate with them. We've got to know how to do some basic things, but then, my training then is okay, this is a complete patient. So, I think you put in your email about it being a full mouth rehab. Let's think about every case not being a full mouth rehab, but a full mouth consideration, a full system consideration. Yeah. So no matter how little we're doing, we're looking to go, if I just do that tooth, is it going to be okay? And then, if it's okay, great, let's just do that, But so I want to be able to look at that. And the traditional way is you would gather records. And then we'd have photographs, we would have mounted models, and then we'd be able to look at that and work out diagnostics, and then work out a treatment plan about where these teeth needed to go to fulfill the goals that we'd set out to achieve. So then, can we start to do those things digitally? And of course, whenever we move to some sort of new sphere, we always try and just mimic what we've left behind. And so for years, many of us, and me included, I can certainly say 7-8 years have tried to copy that system exactly. Digital brings new tools and new ways. A year or two ago, every so often.
What you're trying to say is that you were using digital, but to trying to conform it in the workflows that you had within analog, right? Correct.
Absolutely.
Okay, so where is it heading now?
So, well, what you need to do is every so often, not very often in my life, but every so often you get a moment of clarity, and you think, what am I actually doing? And you get so obsessed. So obsessed with inventing a digital Facebook. It's like, and there's so many hurdles, and you just get into that. When actually you think, okay, and we'll save this for a little bit, but what is it I'm trying to achieve? What is it I actually need to do? Does digital have new ways of being able to do that rather than just trying to copy the old ways of doing it? And so there's things that have made me rethink, and it's about going back to basics. What is it I'm about to achieve? What is it I'm trying to achieve? You very kindly sort of mentioned Pete, and I say in no way would I ever compare myself to Pete. He's just the most amazing guy, But when historically, if you look at the old nathological days, and all the way we would try and measure everything, and then we'd say how everything worked perfectly when it didn't really. Because patients aren't symmetrical. They don't have mandibles that are the same size. They do have a bit of flex in there. They're not made of metal. Biology is horrible. It just does dreadful things to us. But articulators were our best guess. And as a younger guy, Pete came up with this thing, but he said, well, you know what? We do all these things and it's all great, but really, what's it about? Well, what it's about is how do we work ahead of time, make sure that when we actually get the patient in the chair, we're as efficient and predictable and productive as possible. That's it. That's the basic thing. And so what Pete was saying was, well, if I use a semi-adjustable articulator and I use a face bow and we do this, I'm going to be pretty darn close. And so it's going to take me much less time up front, but I'm going to save myself a lot of time at the end. Maybe just as much as time as you did when you spent 10 times more time up front, So, and that was the whole deal of that analog workflow. And certainly, you can call it Dawson philosophy. It's actually Spear, it's Coyce, it's all those things. Because all those people came from Pete's idea, Mm-hmm. And if you read Pete's book, and I was fortunate to get these stories firsthand, but if you read Pete's book, he talks about, it's one of his favorite things was called Blood on the Walls, where he was invited to the Nathological Society's meeting, when, and to hear his new way of doing things. And there was like 1,000 dentists there. And so Pete gave his presentation, and everyone's very polite. And then there was a lunch, and then the speakers were introduced at the lunch, and they introduced everyone. Then the guy who was the big nathological cheese said, and of course, Peter, we want to thank Peter Dawson for his presentation, but we will continue to do the harder right rather than the easier wrong. And, to be put down like that in front of all those people as a relatively young man would see most of us off. Mm-hmm. But Pete had a lot of self-confidence and a lot of belief, and that sort of stiffened his resolve a little bit. And he was also fortunate because the next guy that got up to speak was one of the other big cheeses, and he came up with a big pile of papers. He says, this lecture is the one that I prepare for more than anything else. He said, but after what Peter's just told us, I think I just need to rip it up and start again.
Wow.
And so, and this, so For me, again, in no way a comparison, but I think we're at the same point, which is, oh, well, that doesn't work. This doesn't work. No. It does work. It's just different. And so what we're trying to do is, how do we spend time up front, which just allows us to plan the cases so that when we come to put this into the patient's mouth, we're pretty close. And then all we have to do is a little bit of refinement. And when you start to think about it like that, some of these digital tools are amazing. And they're so much better than what we've ever had in the analog world. I just want to, before I forget, before we get into details of stuff or whatever, there's one part of it that people don't talk about so much. It's almost like a different field, which is this: complete dentistry and full mouth rehabs, or whatever you want to call them, only happen when the patient says yes.
Yes, absolutely.
We as dentists are dreadful communicators. And we say things like, oh, Mrs. Jones, you need 17 crowns, and you need to have equal intensity contacts and posterior exclusion and this and this and this. So when would you like to get started? And we wonder why they don't do it. Digital is a fantastic communication tool. Okay. So, when we talk about digital, we could talk about ways that we can use it in examination, and we certainly use it as for intraoral scans, for getting models. I think that's a routine thing these days. We take photographs. Photographs are, Jazz, because you've heard me say, but they're a great record of what we've done today. They're a great communication tool so that patients can see what we can see, and they also help us in our planning, in our two-dimensional planning. So photographs are still a real important thing. But we need to find ways of engaging with the patients. And it comes back to that sort of story with Amy, which is right at the beginning, which is what are they here for? What's their motivators? Because, they often are motivated they might be motivated by aesthetics, and we're talking to them about biology. Now, if you've got, again, one of my interests was sort of personality types and things, but if you've got that sort of I personality, party person, and you start telling them about the bacteria that's causing their periodontal disease, it might be very correct, and it might be exactly the right thing to do, but it's probably not going to stimulate them to clean their teeth. I need to find the motivator. I need to find the thing that's going to motivate you to do this work. Not for my benefit, but for your benefit. So again, one of the great things about aesthetics is people want beautiful smiles, but if they want a beautiful smile, it allows you to access the health benefits for them. So it helps us improve their biology, because nothing looks better than a nice, natural, beautiful smile. So, and we do nice things for people, then hopefully they look after it. So that's all part of that deal. So, I use digital, in examination, but then I also use it as an engagement tool. It's a real way of engaging with the patient. What's their prime motivation? And I've sort of divided it into three main groups. Are they, just because everyone's like acronyms these days, are they a functional patient? Are they aesthetic patient? Or are they more of a biological patient? So it could be like a fab patient, and very often it's a combination of all those things. But what is, if someone's motivated biology, that's going to be right up our track, because we love biology. We love caries and perio and things like that. So that's easy enough, and we can show them pictures and we can tell them what it is that needs to improve that. Those things are great. But a lot of the patients that I see, a huge amount of them are motivated by aesthetics. Even old fogies like me, we like to look decent. Most of us want to look younger and healthier and whatever. So that's certainly a big motivation. And some people are motivated by function as well, because they can't chew properly, they can't eat properly, or maybe they've lost teeth, and how are you going to make this work for me? So we can use these tools to help the patient understand what's possible, and so much easier than ever we could. So if let's take the aesthetic one, because that's the one that probably is the most common one now.
Yeah.
And is also, it's sort of out there in the bigger domain. One of the things I learned from cosmetic dentistry 25 years ago, was the motivation of sort of smile design, and with digital smile design now, it's a reinvention of an old theme, but
emotional
good luck
dentistry.
to them, I'm always I'm always a little wary of the emotional phrase, because I know they call it that, but it's like there's a thing called buyer's remorse. So just be aware of emotions, so let's call it motivational dentistry or engagement or something like this. But maybe I just can't help being a dentist, but just be careful of the emotional side of things. Let's figure out what's their motivation and then talk to them in those terms. So one of the, again, in the and certainly back to Pete's day and people since then, it's like, oh, well, we take all these models and things and then we mount them up and then we spend 4 hours doing our wax up and then we show that to the patients and they're bound to say yes. And we all said, oh, okay, that's fabulous, And actually, most people are prepared to go along with it because they never do it. And those of us that did do it were so invested in it that we didn't want to say that we weren't that good at it. So it didn't always work out great. The honest truth is, and I'm a bit of an observer of humankind, is that the dentists that I saw that were fabulous at it were actually, they were good clinicians, but more than anything else, they were great communicators, and they communicated to the patients their problems, and they communicated the problems to the patients in the terms that the patient wished to receive them. And that's why they were successful. That's why they got to do the work, So, and the cool thing with digital now is that we can do smile mock-ups and things like this, and we can share our vision, because someone can walk in and just to be arrogant for a moment, and I'm thinking, yeah, I know, I can sort of see what I could do for you. But you've always got to remember, they can't share that vision. We've got to find ways of sharing the vision with them. So, and digital, whether it's photographs, whether it's a 2D smile where we can show them befores and afters, and we can do a 2D smile now in 10 minutes with the great software that we have, or whether it's like an additive mock-up where we can, the way that we do it is we will put down certain markers. I mean, I can't do it myself, but I'll send it to the lab. They would do the design. They send me the STL file. We print the model. We make the stents. We put that in the patient's mouth. It's so efficient. And, it rather than, for me, there was a hole that we all fell into, which was this thing, which is, I need to do a wax up. I can spend 4 hours and it's going to look pretty average, or I can pay the technician, but I'm not sure that the patient's going to say yes. And,
that's the big debate.
That's the way I was brought up, because people always said yes to Pete, because by the time they got to see Pete Dawson, it was a done deal, but Ian Buckle's a different person. It's like, I get patients, it's like, they've got kids at university. They'd rather go on holiday. They've just got made redundant. All sorts of things going on. I have lots of patients, as I've probably told you, with buccal syndrome, which means they've got lots of problems and very little money. And so I want to have solutions that can help them as well. And that's why design is such an important thing. So being able to do additive mock-ups simply, quickly, and cheaply is a big thing, and we can do that now. We can do that.
Are these digital wax ups significantly cheaper than, like, for example, if you send a traditional wax up to a good lab, you're kind of looking at 25 to even £50 a unit of wax up. That's significant. What has digital made it quicker, easier, and more cost effective to turn around this model that you can transfer for a 3D motivational sort of a mock-up, if you like?
So this is where there's a really important part, Jess. So let me try and explain this. So there's a difference between what we might call an incisal-facial mock-up, just to show people the way it is, which sitting on my high chair judging everyone, I would look down upon, because where's the function in this? So there's a difference between that and a proper fully functional diagnostic wax-up. But there's a big gap between patient, fully functional diagnostic wax-up. This additive mock-up can be the link, I think. Well, I know it is. It certainly is in my hands and in my practice, because we can do those. And I'm working with some of the labs right now. You're going to be seeing some things pretty soon where we can do those inexpensively. Okay.
Brilliant.
For a lot less than because that's the problem. You're sitting there thinking, I need to spend, let's say, £30 a tooth on this. If it's a smile, let's say it's 8 teeth. And you're saying to a patient, okay, it's sort of, let's say £500 to do this. It's like, that's a big leap for someone that's not sure. No, if you've got someone who's totally motivated, that's a different thing. But those are the easy ones, But we have a lot of patients who aren't sure, and to spend £500 to do something that they're not convinced about. So the journey, as far as I'm concerned, with engagement is, first of all, photos and doing all the things that we do. I don't want to lose track of that. I think a great co-diagnostic examination where we're explaining to patients what the problems are and how we can help them with what they'd like to achieve is super important. Photographs, real simple and really, really important. And then we come to that decision. Is this a general patient, someone who just wants to deal with the biology? Or maybe this is a complete patient in waiting, Like one of my mentors, Larry Gazzardo, tells me, don't forget, date them before you marry them. It's not a bad idea to get to know someone before you start doing big stuff, And Tiff Qureshi, as you know, is a big pal of mine, and Tiff talks about the same things. These things don't have to. You see all this stuff. I mean, on Facebook and Instagram, and as if like the patient came in, we did that. The patient came in, we did that. There's nothing wrong with getting to know people, and. If biology needs to be resolved, let's get that resolved. But at the same time, we're getting to know them. We're seeing whether they respond. Do they turn up? Do they pay their bills? So we can get to know someone before we move to that next stage. But let's say we show them the photos and they're showing interest. Well, we can do a 2D smile design with some very simple software. I mean, we tend to do that for free. It takes about 10 minutes and it gives them an idea. And then if they're motivated...
You do that yourself, Ian, or I'm just learning about because I want to make it tangible for those listening. So this part you do yourself, or is that something that you're now outsourcing to labs? Because labs offer this sort of smile mock-up service in 2D images.
So let's just talk about that for a moment and try and keep my focus on the bigger picture. But let's just talk about that for a moment. I'm really, really keen on our relationship with good technicians who know what it is that we're doing. I have a lot of tremendous technician friends. And so when I say this, I'm not trying to be unkind to anyone. But again, like we talked about the orthodontist who has the same goals, we have to work with someone who has the same goals. You can't just send this to someone and get what they think, We need someone who is on the same page as us. I'm fortunate. I work with Lee Kulp over in the States, Shemek Svinek, who's over in Sweden. And we just communicate digitally. I work with Phil Reddington. A lot of you know of Beaver, who's all tremendous. We do different things together, but we have the same goals, and they know what my goals are. They know what it is that I'm looking to achieve. So, we need to be able to do that. But if, as far as this is concerned, we can get the technicians to do as much or as little as we like. So my journey with this is, when the smile design software first came out, I thought it was a pain in the neck. So I used to get Shemek to do it for me. Now it's really easy. So I learned how to do it. I'm a bit of a old-fashioned leader, in that I like to stand at the front waving my gun saying, follow me. So it's like I would use it to start off with, and I learned how to do it. And now, my assistants, they're not nurses because they do so much for me, but my assistants are trained to do it. So they would do the smile design for me in 10 minutes or so, so
that's brilliant.
And this is the thing, and this is so by all means, you can take the pictures, send it to one of these great labs, and they'll do something for you, no problem. Very often they'll do that for free. They'll see, because it doesn't take them long to do. But because we've got the software, we're able to show someone real well. And, as far as your staff is concerned, do they want to just stand there and suck spit and mix usinol, or would they like to be taking photos, doing smile designs, doing all these things, and really making the most of their job? So those are the people that I'm looking for. So in our practice, we started off, the technician was helping me, then I learned how to do it, and now mainly the staff are doing it. I still do it occasionally, try and keep my hand in. But you can choose whichever of those is appropriate for you. What I'm hoping is that you just get involved, and once you get involved, you'll see the benefits in learning yourself and getting your staff trained as well. Okay, so that's the 2D smile design. The additive smile design, I think, is something that you could probably learn. But, to be honest with you, I have guys, in various parts of the world who are amazing at doing this. And here's another obstacle for us. Oh, this stuff costs so much money. Well, why? Well, it costs money because we have to buy the software, and then we have to spend lots of time learning how to do it. If I know someone who knows how to do it, and if I can describe to them exactly what it is that I want, they do it. Then we go on TeamViewer, and I can say, could you change this or this or this? They make those tweaks just to make it look as though I'm actually in control. And then they send me the STL file, and we print the STL file. And now we have a smile design in no time at all. Really, really efficient, very, very effective and cheap. And a great way.
How cheap we're talking, Ian? Because I want numbers. I want numbers.
You would want numbers. This is something I'm working on with some of the labs at the moment. Okay. And I know no one's listening, Jazz, because I know I've learned from your time with us that no one would listen to you anyway. So I know no one's listening anyway, so it's okay. But as you say, typically you're looking 20, 30, 40 pound a unit. I think we can definitely do these things because, there's two ways I was looking at this. Is if I said, by the time I've got the patient to this point where I'm thinking of doing this, what's the number that I think would be high enough to get rid of the tire kickers, but low enough to have them do it. Okay. Sure. And I think somewhere between £200 and £300 is a reasonable figure. So if we could do this for say 10 to 15 pounds per tooth, it's costing you maybe 120, 150. And you said to them, Mrs. Jones, we could do this, and we can actually show you what this would look like in your mouth for £200. I think that's a good place to be. And I've spoken to lots of other people about it. And I think, I'm not a great one for totally free. I think we do ourselves down by that. I think there's lots of people out there who will take the mickey out of you for it, and take advantage of you. And I'm being polite right now. So, but I think that's a figure that, if we could bring that additive smile design in for, somewhere between £100 and £150, and you were charging the patient £200, I think that's a good place to be. I think if the patient isn't willing to invest £200 at that stage, it's probably not going to happen, So that's sort of what I'm working at. But let me tell you this, it's not just an additive smile design, okay? Because this is the thing, isn't it? Which is, okay, so we put this in the patient's mouth, and they go, wow, that's amazing. And then we have to start again to work out how to make it work, okay? So let's think about being able to use that additive smile design to really enable function. Okay. So let's think about the three main things that we talk about in function and treatment planning function: upper incised ledge position, lower incised ledge position, vertical dimension. Okay. So if you think about it, if we do an additive smile design really nicely, we have the upper incised ledge position, we have the lower incised ledge position, and then what we need is a little bit of knowledge to work out the vertical dimension. And now we have everything in place to do the full diagnostic wax up. So it's not
into
just
the next part. That's fantastic.
it feeds into the next part and will make the next part even easier still. So let's take the simple one. People don't think it is necessarily the simple one, but the simple one is generalized wear, because it's easy, because we're going to, without going into the occlusion bit, open the bite a little bit, have some space. So if we add a couple of millimeters to the upper incised ledge and maybe a millimeter to the lower incised ledge, then we can see how that looks in the patient's face. And then we've just got to think about, where do they come together? Do we reduce at the back? Do we add to the front? Or is it a combination of those two things? And that's, might be it's a big topic, as you know.
And that's far beyond a podcast episode, but it's just whetting everyone's appetite for digital, understanding your workflows, Ian, and already you've told us about how easy it now can be to have that 2D motivational photo, and to the extent that now you've got your staff trained, which is amazing. And then you've talked about going to the additive mock-ups and how that can feed in to the next part, and that's really great. So,
well, let's also think as well, Jez, about sort of how that whole thing fits together, because we talked a lot about individual parts there, So, that's sort of the whole picture. So, and you said to me, one of the questions you asked or mentioned to me was about, when I take a bite at the right vertical, I seem to be very successful. And that's absolutely one of the keys. It's an old trick that we used to use with splints. That if we took the bite at the right vertical, we didn't need all the face bow stuff, or all the big articulator, because we weren't playing with the arc of closure. It's the same with these things. So if we're just playing a little bit with that, maybe we don't need all the old style face bow stuff. Now, there are times, and the key is to understand when those are, when we might need a little bit more information. But to come back and say, okay, what's your protocol, Ian, for records for smile design, full mouth rehabs, comprehensive patients? Well, so we do our complete examination. We do photographs. We talk to the patient about what's there in the terms that they would like to receive it. And then if they're motivated from the aesthetic perspective, then we'll show them a 2D smile design, and we'll get them, if they're then motivated to spend that, let's say £200 on their smile design, then we'll move forward with that. Now, for that, here's what I'll take, is I will take scans. Now, for those of you, because I was only joking before, I know loads of people listen to you. So for those of you who are analog and would like to stay analog, you can still take impressions, and we can have those scanned by the technician. Okay, so you can get into this whichever way you want. For me, the real power of digital is in wax ups and treatment planning, etc. So you can take that, we can take an impression and have it scanned. Obviously, I'm hoping that eventually you just say, "Oh, it's a waste of time. That we should just get a scanner." But we take the scans, we take a bite registration, and the bite registration that I'm going to take it from my place in a stable condyle position. You can choose whichever way you'd like to do it. I'm going to choose a stable condyle position, and I'm going to choose the vertical dimension that I think is most appropriate for that patient. So, there's obviously some thinking that goes into that we could maybe discuss another time. So we take a bite at that stage, and then often now we'll take a face scan as well. And the reason why we take a face scan is because the photographs, we can set the patient up pretty well using the photograph. But with a face scan now, I mean, I can take my iPhone out and I can take a face scan on this. And then we can use that, and we can with things like Bellis 3D, we can incorporate the intraoral scans together with CBCT scans into the patient's face, and we have a virtual patient. And now the technician can actually see the teeth sitting in the patient's face. I mean, that's amazing, isn't it? And when you think about
that, essentially is your face bow, then, right? Done. So, but before we get into that, I mean, this whole scanning the face, something I'm not doing at the moment. It's a very new concept for me. And you mentioned some software that you can use for that. In terms of one of the questions I had sent in is that if you're relying on your photographs to become your digital face bow, Is that a good entry point into transferring that information? And if you don't mind, Ian, just for the listeners who are hungry, a lot of young dentists listen, what is the main benefit of a FACEBO in general cases? Why even bother, right? And then how would you transfer that using photographs to a laboratory along with the scan? Is that a predictable way or not?
So this is where you have to come back to basics. I think in the analog world, a FACEBO, so where that came from in the old pathological days was a hinge axis recording, which, if any of the younger guys and girls want to go on and look at that, by all means do so. But it looks like something from a museum. And there's still things that we can talk about with hinge axis. It's quite interesting because I'm sad. But we then move to this earbow or FACEBO, whatever you want to call it. There's a few different varieties out there. And really what we were using then is like, this is a quick and easy way of transferring information to an instrument, which in some way replicates the masticatory system. That's what it's for. So what did it do? Well, it went in the ears. So we said, well, we're relating the top teeth to where the condyles are. Okay. We're also then, that's going to help us with the arc of closure, because that's important if we're going to take a bite at an open vertical, or if we're going to play with the vertical dimension. And we then used it to give us some idea of the incisal plane. So let's blow up a few sacred cows, seeing as it's just me and you.
Has to be done.
Let's think about that. Well, don't get me wrong. If you're in the analog world, this is still a great way of doing it, okay? Because it's going to give you a lot of great information, and I've done it for years, and it works fab. So, but let's think about it. So we put it in the ears. Well, where do we're actually looking for the medial pole of the condyle. Well, unless you're pressing real hard, you're not getting there. So far too hard. So, what do most FACEBOs do? I think they allow, excuse my lack of knowledge, but it's something like 9 millimeters, because that's where we think that is. Well, look at my fat head and then look at lovely slim Jazz. I think we're probably a little different. So we're making an assumption straight away. Okay. And then if we're going to use it to get the incisal plane, what are we going to do? I'm actually going to fudge it round in the ears a little bit. Oh, that's super accurate. Okay. And then it's going to be the arc of closure. Okay. So you can see that it's good and it's quick and it's easy and it works better than the other stuff, better than doing nothing. But here's the thing. If we think about all of those pieces that we just said, is why do we need the arc of closure? Well, we need the arc of closure if we're going to mess with the vertical. But if we actually take the bite at as close to the right vertical as possible, maybe that's much less important. Okay, which is why you've been successful with those things, as you mentioned.
So just to roll it back, I mean, the reason Ian mentioned this, guys, I emailed Ian a little bit about what we're going to talk about. And one thing I told him was my experience of digital so far is when I've recorded the vertical dimension near about where I want the patient to end up before I restore them, I found that once I've done there, and typically it's composite with my level of experience at the moment, moving more to ceramic, but at my level at the moment, quite junior, doing a lot of composite work, and transferring the sort of digital wax up into the mouth, and then getting the patient to close together. And this is after usually I've deprogrammed them. We're using a deprogramming appliance, and that's a whole another section we can talk about. I found that when they bite together, I've got these beautiful contacts, and the excursions are just where I want them. So it just needs a bit of polishing. And the first time I did it, it blew my mind. I thought I fluked it. Then a couple of times I did it, it became very reproducible. And it's exactly the reason what Ian just said. When you record it at the vertical, you remove that element of potential error of actually opening the vertical. So that's what Ian's been talking about. And now going forward from that, the questions we've had is, we've essentially answered it, Ian. The virtual FACEBO is essentially what you're using is a face scan incorporated. But one thing I perhaps misinterpreted was that you said the CBCT, but if you've got a comprehensive patient who does not need implants, but you're doing comprehensive dentistry, so you want to transfer that information. Would you be taking a CBCT to as part of your records to then be able to relate that to a virtual FaceBow?
Okay, so let's talk about relating or sort of that virtual FaceBow thing and see if this answers the question for you. One of the things that relates to that correct vertical, the correct vertical only works with a stable condylar position. So let's be clear about that. So if we think about what we've just said about FaceBows and how we relate the teeth to that and how do we do it, we can choose a photograph that will be reasonable. There's certain things we put to 2D to 3D. We can use a face scan, which will give us more information still. We can use a CBCT scan if we have one. Now, I think it's grossly inappropriate to be taking CBCT scans to mount models. Many of the patients that I treat have joint issues, ortho issues, implant issues, and I've got good reason to take full volume CBCTs. But I also have a lot of patients, more smile design. It's inappropriate, So we're taking appropriate radiographs, appropriate radiation. And so if we have one, that's probably the most accurate way of doing it. But if we don't have one, perhaps a face scan is the most accurate way of doing it. And the next thing that we can mention, but there's a reality to all this as well. A photo is quick and easy and cheap. We all know how to do it. Mm-hmm. A face scan these days is quick and easy and cheap, and it's easy to learn how to do. CBCTs, if they're necessary, are there. That's one. Then we have things like Module, which are more like jaw trackers, etc. And they can give us tremendous information, and we can combine that information with the intraoral scan, with the CBCTs, and we can actually record the hinge axis. What used to take us hours would take 5 minutes these days, So it's amazing information that we can get from stuff like that. But there's a cost that comes with that. And my goal with these things is to get the best treatment for my patients. And then if I can encourage other dentists to do the same, then I think I've spent my time well. And my other goal is to get dentists sufficiently interested that it makes their want to treat patients well, but also makes their days more interesting, because we all spend 8 hours or so here. You may as well have an interesting day. And,
absolutely.
But also as well, I think many of us over time have bought expensive pieces of kit that we didn't particularly get a return on the investment, So things like Module, I think are great. I think there's huge amounts that we're going to learn from things like that as far as research and education. And I think as far as, treatment's concerned, it's a really valuable tool. I think at the moment it's at the high end of cost. It's not something that I would suggest go out and buy one. If you like stuff like that, go out and buy one. You'll have great fun with it. It's great fun. And you might be, you'll be able to, patients will think you're amazing, all those great things. So I think it's a great tool to have if you're going to make use of it every day. Okay. I think that going forward, these sort of technologies will get incorporated more into the other things that we've spoken about. And like everything else, they'll tend to come down in price a little bit. And it will become part of what we do. I'm absolutely convinced about that. At the moment, there are things, I think in some of the cases that I do, Module is incredibly important. But for some of the simpler things that we do, it's interesting, but it's not as important. Mm-hmm. So I think if we look at that, so I don't, because the people at Module are fantastic, and I encourage you to look at it and to think about it. And if it floats your boat, get yourself one and get involved. And I'm really enjoying working with it myself. But it's no good having something like that if you're doing just a couple of fillings every day. It's not going to help you too much. So let's just recap over those. So we can use a photograph, simple, easy, cheap, going to give you a decent result. Face scan, simple, easy, and cheap, going to give you a pretty good result. CBCT, if appropriate, so relatively simple, easy, and cheap, if it's the right thing to do, and super accurate. And then modular, super accurate, but a little bit more expensive to it. That's the overarching thing. And then let's compare that to FaceBow, easy, cheap, and I then have to take the FaceBow, take the models, mount the models, do all those things. Lots of time. I mean, now I can take my scans, take my bite registration, and check my first point of contact in 10 seconds. Usually we'd have to cast the models, mount the upper model with a FaceBow, mount the lower model with a bite registration, and maybe 2 days later, I get to check the bite. Mm-hmm. I mean, I'd sort of forgotten about that until one of my pals actually pointed out to me. He goes, well, "You do that right away?" And yeah. So I can tell if I'm on the money straight away. So there's so many things that help us: predictability, efficiency, productivity. That I think we just got to think differently. So that's my view on FaceBows now. I think if you're in the analog world, it's still a great way to go. Mm-hmm. But otherwise, I think we have other ways which are, let's say, just as effective.
Well, that was the most common question that had come up. So thanks to those who sent it in. Now, in the interest of time, we're going to have to wrap up. So one of the questions which I think I do want to learn about is Sid Gupta. If you remember from Dawson, I met him at one of the Dawson events. Sid, young dentist, and when he one of the part of the courses that we did with you is that we get to present our cases, and his photography and his motivation was just fantastic. I believe he's in Wales. Fantastic young dentist, really great work. He wants to know when your digital course is coming out. So if you'd answer that.
Well, as you may know already, I'm probably about the worst salesman as far as dental courses out there is concerned. So they are coming soon to probably unfortunately to a webinar near you. So, but they're coming soon. I'm working with the guys. What we're hoping to do. I'm actually, that's as soon as I finish with you, that's my afternoon is working on those digital courses, because what we're aiming to do, and it's a little bit related to this beautiful COVID situation that we're all in, but actually it was something that I was working on before, which is the idea that we could have smaller groups in a location that was more appropriate for you. So say for Sid down in Wales, because let's face it, who else wants to go to Wales? And I haven't been rude about them for ages. For those of you who don't know, probably 50% of my patients are Welsh. So we always mean to the people who live next door. So, and I'm a Scouser, so I've got no chance, have I? So, but the idea is that maybe we could have that we would do a little bit of lecture, which would be centralized, and then in that smaller location, you would then do a hands-on exercise. So let's taking the intraoral scan, taking the bite at the right vertical. So we're going to be rolling those things out pretty soon. There'll always be the opportunity to come here and time me where I do it, but so that's but you're going to be seeing those things very soon. And what's great for me, is you're very kindly invite me to this sort of thing, Jazz, and I know you have a lot of listeners and people like Sid. It's what's been very, very rewarding in recent times is to have these young people who are far more motivated than I ever was at that age. I know if we can just encourage them to do a little bit of learning every day, every week, every month, they're just going to be such great dentists and get such payback from this, and their patients are going to be so well looked after. That spending our time doing these things will be well worthwhile. So the courses are coming soon. Jazz, I'll try and make sure that you're the first to know. And if you can let these people know, that would be fabulous.
Yeah, I want to put that on because usually people usually swap me on Instagram for information, whereas it's usually on the website, protrusive.co.uk. So when it's out, I'll update the sort of blog post associated with this episode. So we've covered a fair bit. I mean, it's impossible to get into nitty gritty detail bits that we all love in just a video over 45 minutes or so, which was the aim. But I think we've covered a good deal to everyone's appetite about you talked about communication. That's so important about how to actually communicate and find out what motivates that patient. So that itself was just phenomenal. We talked about 2D Smile. We talked about the additive mock-up and how you price that. So we talked about the business element as well. It's like a lost leader, but it's one way to get that patient on board with the vision, and how you beautifully took it to the next stage with implementing it into the upper incisal, the lower incisal, and the vertical dimension. We talked about a few hacks with the vertical dimension in central or stable condylar position, and it's come beautifully to full circle now. So, Ian, thank you so much for your time. Is there anything else that you wanted to put out there?
It's a big old subject. I think, it's a combination, of new ways of doing things. Digital is exciting. As I've been doing this 35 years, my daughter's just starting, just about, she's with all this A-level chaos. She just got into do physio at Sheffield. So it looks like I'm going to be working for a while longer yet. While we're going to work, I think we have a duty to our patients to do the best we can. And we have a duty to ourselves to enjoy every day as much as we can as well. So, and all these things help us to do that. And so I appreciate your time, and I appreciate your listeners' time in listening to us go on about dentistry. But we spend a lot of time doing it. We may as well make it as fun and productive and beneficial as we possibly can. So that's sort of what it's all about.
I really appreciate that. Thanks so much, Ian. And I will catch you at the digital course probably. Thank you. I
hope so. Thank you.
So there we have it. I did tell you that you would love his stories, and I really hope you gained value from that. As always, I really appreciate you listening all the way to the end. If you could do me a massive favor and go on YouTube, hit that subscribe button, and whichever podcast platform you're listening from, please hit subscribe, and please tell a friend. That's how the podcast grows. Next episode is going to be awesome. It's with Payman Langrudi, all about whitening in a way that you've never thought about it before. Like, how can we do more whitening? Why we should be doing more whitening, and a few tips and pearls to get better, successful teeth whitening outcomes. So come and join me on that one next week. Same time, same place.